Good morning. The Committee on Insurance and Financial Services shall come to order. Madam Clerk, will you please call the roll to establish a quorum?
Madam Chair,
Present.
Representatives McFall,
Here.
Coleman,
Here.
Stone. Here. Green. Rogers. Here. Scott.
Here.
Young.
Here.
Fitzgerald.
Here.
Grant. Harris.
Here.
Markkinen.
Here.
Fasad.
Here.
Aragona.
Here.
Barak.
Present remote, Brenda.
Nair.
Here.
Smith. Madam Chair, you have 15 members present. You do have a quorum.
Thank you, Madam Clerk. Now we need a motion to adopt the minutes of March 23rd, 2023 as printed. Representative Fitzgerald moves that motion. With that, hearing no objections, the minutes are adopted. Ladies and gentlemen, the first item I would like to bring before the committee is not on the agenda and is of paramount importance. Seated next to me is Committee Clerk Joy Brewer. Effective tomorrow, Clerk Brewer will begin her much-deserved retirement. Over the past 3 decades, Clerk Brewer has been a mentor to countless committee chairs and staffers. Her dedicated work to protect this great institution we all served is unmatched. On a personal note, I am proud to call her my friend. When a staff member departs the Michigan legislature, it is customary for them to receive a state seal. Clerk Brewer, you have more than earned and deserved this honor. So, would you please accept this seal on behalf of the Michigan legislature in the House of Representatives and the Senate for your exemplary work? I truly believe that there's no person more deserving than you, and I'm gonna miss you. You know that, don't you? I'm gonna miss you. So thank you, everybody. Turn this around so they can see.
Thank you so much. You know what we say to our family and friends of home? Love you all to pieces.
Thank you. Thank you. And now, on to our agenda. And we will hear testimony of House Bill 4376, which I introduced. The committee now will go at ease.
The Committee on Insurance and Financial Services will come to order. What am I supposed to say? Oh, okay. Okay, thank you. Sorry, this is my first time. Today we have Chair Rep. Carter testifying on her bill. Thank you for testifying on this.
Thank you, Mr. Chair, and thank you, committee, for allowing me to speak. House Bill 4376 is important legislation that will update our laws on the duties of fiduciaries. In the insurance industry, insurance agents represent insurance companies. Agents look for clients who will buy insurance. By contrast, insurance brokers represent insurance buyers. In other words, brokers look for insurance products that will meet the needs of their clients. Insurance brokers must act as a fiduciary, and they are held to a higher standard because they put the interests of their clients first. A fiduciary is a person or organization that acts on the behalf of another person or persons, putting their clients' interests ahead of their own, with a duty to act in good faith and trust. In 2005, the National Association of Insurance Commissioners issued the Producers Licensing Modeling Act, which combines the functions of an insurance agent with the functions of an insurance broker, which they all fall up under a banner called an insurance producer. And that's basically it. It all falls under one umbrella. So therefore, producers should be held with the utmost respect and dedication to their clients. Under Michigan law, fiduciaries are not required to keep their clients' money separate from their own personal money. This bill updates fiduciary responsibilities and record keeping for insurance agents, brokers, and producers. The bill also makes clear in statute that there will be no commingling of funds with monies that belong to the agents. The bill is a priority of the Department of Insurance and Financial Services, prohibiting the blend between client or insurer funds with money of agents is already strongly discouraged and is an insurance industry best practice. However, there is nothing in statute that prohibits this explicitly. This is why I am encouraging you all to support this legislation. I would like to thank you for your time, and I will be happy to answer any questions.
Thank you, Rep. Carter. Does anyone have any questions? Rep. Fitzgerald.
Thank you. Thank you so much, Representative Carter. One thing that I'm just hearing within all this and being within the industry for the past few years, you know, my understanding is that this would potentially eliminate or reduce the risk of rebating for an agent essentially to pay a portion or all of an insured's premiums or reduce those in any way. Can you tell me a little bit more about, you know, the abuses that we may have seen within the system currently that have inspired for this to occur? You know, what is the environment where this is occurring, and how are we looking to, or how will this correct that?
Okay. Thank you, Rep. Fitzgerald. And to my knowledge, I'm not sure if that's an issue, but we do have Joseph Sullivan here who tracks these things with the Department of Insurance and Financial Services. So if we could have him speak to it.
Call Dips up.
Oh, okay.
Join the chair.
Just call him. Just call him.
Yeah, just ask Dips to come up.
Oh, if Diffs could come up, that would be great. Thank you.
Apologies for the technical question.
No worries. That's a great question.
Appreciate the question, and that's why I brought my technical expert, Michelle, here today to answer that.
You have to introduce yourself for the record, please. Thank you.
Michelle Rittering. I'm the Office Director for the Office of Insurance Licensing, Audits, Investigations and Audits for Department of Insurance and Financial Services. We have seen some rebating where producers will pay. Many times sometimes they're not even aware they're doing so. We've seen cases where when the funds are commingled and there's overdrafts in accounts, it's where premiums are not being remitted timely or refunds are not being remitted timely. We've seen cases where they can't differentiate between the funds, so they don't even know if coverage is bound because they can't even follow the money. We've got where premium funds are being used to pay operating expenses. We've seen failure to ensure that refunds due, like unearned premium, unearned commission, overcharges, overpayments, they're not made timely or not even provided. We've seen cases where it goes, beyond like 3 years where things are not paid back to the clients, the customers. Failure to provide documentation on cash payments or even on checks that were paid for premiums. And they're unable to, there's no documentation. So if you have the separate accounts, you're able to differentiate a lot better. So those are a lot of the different things that we see.
A follow-up, if I may, Mr. Chair.
Yes, go ahead.
Thank you. When that money is taken in and utilized in the accounts, in the understanding that I have is if the account is required to have a startup cost, is that it's done so with producer or agent money, then withdrawn upon an initial deposit from the premiums collected. Based on any of the financial institutions that we have, there are a number of mechanisms where interest could be gained on various accounts. Is that something that is barred as a part of this as well, to collect an interest or any type of gain from the monies being utilized in those accounts?
I believe it's part of the bill that it is not prohibited. Correct.
It is not.
Correct, they can earn interest.
No, yeah, so that's a really good question. And throughout the process, we were able to work with stakeholders, and that's one of the things that we were able to add to this language is specifying that financial institutions that must be used are state, federal chartered financial institutions that are federally insured, and they are allowed to be interest-bearing accounts, specifically in the language.
Thank you.
Rep. Rogers.
Thank you. My question is probably for DIFS too. How widespread is this problem? Do you track it? Do you have any kind of data collection about it? Thank you.
I don't have specific data at hand or on hand, but we do audit agencies. So we do go in, and it is very, very frequent that we see for those agencies that handle premium payments. Some are direct pay, so obviously those ones don't have this issue, but those that actually handle premium payments, we do see a lack of accounting, and we do see this issue. And it is very difficult to follow that money and to kind of determine when premiums are paid and to tie that to the customer and to the policy. So.
And then a follow-up, if I may.
If you choose, let me see.
Yeah, go ahead. Thanks.
Thank you. Sometimes you issue bulletins on various things that don't have specific legislation. Have you issued a bulletin on this topic before?
We have a document actually that was put out in 2014 that we are working on updating for our insurance agency best practices. And we do issue bulletins from time to time, but we have our best practices out there. So
Thank you.
Thank you. Does anyone else have any questions, excuse me, for Rep. Carter?
Well, Mr. Chair, I don't know if this is appropriate. It's my first time over here, too. But this has informed me that they did have, you wanted to speak to it?
That's when you're back in the chair.
Oh, that's when I'm back
Yeah.
in the chair. See, I told you.
That's okay. It's a learning experience.
Thank you. All right.
Thank you, members, for your questions. The committee is going at ease at call of the chair.
The Committee on Insurance and Financial Services should come back to order. Now, we are here. Now we will hear testimony. No,
They wanted to testify.
this one, okay.
Yeah.
So,
Remember that question that they asked? You can go.
I've been informed that I can ask the bill drafter
For that
to,
question.
to clarify the question that,
You said she didn't know,
right,
that she wasn't sure of.
the one that you weren't sure of, Michelle, if the bill drafter chooses to,
Which question was it?
it's not necessary?
No.
Okay.
No.
Okay, so now we'll move on to testimony from Joseph and Michelle from DIFS. Thank you.
Yeah, thank you, Madam Chair, for taking up this consumer protection bill and for giving that a really good overview. I thought I would complement that with some of the department's perspective on this bill. So, you know, as everyone knows now, House Bill 4376 requires insurance producers, often called agents, to keep consumer premiums in separate trust accounts. So what would this do? An insurance producer would be prohibited from using client funds for purposes other than the transaction of insurance. Producers would be required to hold consumer funds to solely pay insurance premiums and other expenses related to an insurance policy. And this ensures that consumer funds are not used by producers for general business or any other purpose not related to the needs of the consumer. And as Michelle said, it codifies what is considered a best practice within the industry and DIF's guidance. As current law does not prohibit producers from borrowing funds from their clients, this omission could create opportunities for agents to mishandle those client funds, and this bill simply closes that gap. So what is the purpose of a trust account? A trust account would be used to pay insurance premiums and other expenses related to an insurance policy. The producer would be prohibited from commingling those consumer funds with any of the producer's other funds, and this would ensure that money is intended to purchase an insurance product is actually used to purchase that said insurance product. So I can talk a little bit about why this bill is needed from DIF's perspective. So similar protections are common in other states, about half of the other states that we've looked at. However, this proposal has not previously been introduced in Michigan. Currently, there is no law that requires consumer premiums to be held in a separate account or otherwise prohibit producers from using those funds for general business purposes. Again, these funds should not be used by a producer for other purposes because they have a fiduciary responsibility to their consumer. And DIFs, nor frankly agencies, want those bad apples, right? So really this bill is just a common sense consumer protection. This is the consumer's money and it should be protected. Additionally, more than half of the audits conducted by DIFs result in a referral to enforcement for premium compliance violations. And this requirement for a trust account is driven by the need to establish a control to safeguard those consumer premiums. And another thing I wanted to note that DIFs, along with the chair, were able to engage with stakeholders during this process. We addressed some mostly technical concerns with the language before us, which includes some items like adding a provision to allow business funds to be used to start an account or pay for bank fees so long as that money is accounted for, ensuring that the language and terminology is consistent throughout the language, and specifying which financial institutions that can be used, as we discussed earlier. And then we also added a 180-day implementation window, which would allow for agent education on this reform. So we believe that this language is getting close, and we're hopeful that we can move forward on this consumer protection bill at a later hearing. I will say that a sub will still be needed to address a few minor technical things, and I know we're working with your office on getting that finalized. So once again, thanks for having us in this morning, and we'd be happy to take any additional questions that members have.
Rep. Fitzgerald.
Thank you. One question I have is with regard to failure to comply. Is there a financial penalty to this? Is there a loss or suspension of licensure? Can you describe the process by which this would be enforced?
Sure. So the insurance code, Chapter 12, is for insurance producers, and Section 1239 does talk about suspension, revocation, denial of licensure, and then refers to 1244 for the civil fines and penalties. So there's a $1,000 fine for each violation. And if the person knew or reasonably should have known, then it's up to $5,000 for each violation. So, and those fines cannot exceed, I believe, $50,000. So there are fines that do occur.
So with regard to Chapter 12 then, and the revocation of a license, is that on any offense, or with regard to Chapter 12? I'd just be interested to know when and how that license may be revoked or suspended, as it may, if there's an agency that is a sole proprietor, there's one agent there, that person's license is suspended, there may be dozens, if not hundreds of clients who could be affected by that revocation for potentially knowing or unknowingly not abiding by this new law. And so I'm just curious about the enforcement of Chapter 12 then as associated to this new language.
Well, with anything, with any of our audits or investigations or any actions that we take, we follow due process. So all agents are they are afforded a hearing, so they have the ability to say. So we work a lot with agents, even through the audit process. When we go into an agency and audit, our number one goal is to bring them into compliance and to educate. So that's our number one goal, even throughout our investigations. We want to educate the insurance industry in Michigan. We want to make sure our consumers are protected, and we want to make sure that everyone's brought into compliance. So that's our number one goal. Our number one goal is not to revoke, not to suspend, not to fine, not to bring all of that in. It's to make sure that our consumers are protected and that our industry is educated. So it's mainly the very egregious violations that you would see that would go toward a revocation.
Thank you.
And just to add briefly, none of that language is being added in the bill. That's existing language that's in the insurance code. It's just for non-compliance that they would be subject to.
Yeah, thank you, and understanding that relationship between the current code and the proposed language is appreciated. Thank you.
Thank you, Rep. Fitzgerald. Are there any other questions? Okay, hearing none. Thank you very much for your testimony and information. We appreciate it. Next on our agenda is a presentation from the Michigan Association of Health Plans. Here today is Dominique Pallone, Executive Director of the Michigan Association of Health Plans. Thank you for coming. The floor is yours.
Thank you, Madam Chair, and thank you, members of the committee. I appreciate the opportunity to be here before the committee today. At your desks today, we've provided you with a packet of information, which includes a copy of the PowerPoint that we'll go through here today, as well as some other materials on issues of importance. As the distinguished chair noted, my name is Dominic Pallone. I'm the Executive Director of the Michigan Association of Health Plans. And I'll do my best to get through the slide deck. I realize that I'm about to give the Insurance Committee a presentation on health insurance, and there appears to be no coffee in the room to keep everybody awake. So I apologize in advance, but I'll do my best to move through these slides as quickly as I can and then answer any questions that members may have. First, I'll give you a little bit of background on who we are and why we are here today. Our association represents 11 different licensed carriers in the state of Michigan who provide healthcare insurance for more than 3.5 million Michiganders. We also have about 50 different business affiliates. We have several affiliate levels of membership of our association. We've listed a few of the names here that you may recognize. Our member health plans employ over 8,000 employees throughout the state. And so we're not only large carriers providing access to a large number of the population to important healthcare services, but we're also large employers throughout the state of Michigan. And here today to talk a little bit about healthcare markets, formally introduce our association to this distinguished committee, and to commit to the chair and to all committee members to be a resource to you all should you need us in the future on individual pieces of legislation as well that we may come back before the committee to testify Just wanted to show you all logos of our membership, give you a sample of the members, the health plan members that make up our association. And as I noted, we do want to be your resource throughout the years. Whether we have the expertise on staff, whether our member health plans have the expertise, or whether we contract to bring in experts, feel free to lean on us as you're seeking information or background materials on important topics. You'll see some of the concept papers that are in the packet. We'll be producing more of these as the year goes on as well. And then we can also help you in your offices on your constituent responses regarding healthcare issues. So should the need arise, please feel free to contact us. I'll just spend a minute here talking through the various markets in Michigan, give everybody a high-level overview of where Michiganders are receiving their health care today. The individual market, it is what it sounds like. It's for individuals and individual families. This market oftentimes gets a lot of attention as it's related today to federally facilitated exchange that Michigan operates on. There is some legislative discussions just beginning, I think, around a state-based exchange. I'll have more on that in a second. But it does get a lot of media attention. And as you'll see here, in Michigan, it only makes up about 3% of covered lives in the state. Other areas that our membership is engaged in, obviously, is in Medicaid, where during the pandemic, obviously, those numbers have grown. We're about to go through a redetermination period here that a large number of individuals will lose coverage. And our job throughout this process is to try to keep those that are in Medicaid rightfully in Medicaid and enrolled, and those that no longer are eligible for Medicaid, we want to work with them to make sure that they have options to transition to other levels of care. That may be employer-based, it may be the individual market, it may be other options that may be available to them. So you have our commitment to work with that population. Our membership will be is already working heavily with that population through this difficult transition time over the next 12 to 14 months. Medicare, obviously a lot of attention at the federal level with policies and changes that may be coming down the pipeline from CMS and from Congress, but it makes up about 20% of the Michigan market. As our population ages, I think the slices of the pie here may change, and that's likely to be a growing market just as our population ages. And then the biggest group, obviously, employer-based coverage, which represents about 51% of all coverage in the state of Michigan. Not listed on this chart, but an important statistic to bring up is uninsured, right? This chart is focused on those that have coverage. But I know it's a point of importance to the chair and to members of this committee and an importance to us and our members that we're working on trying to find ways to increase access to care at an affordable rate. We still have an uninsured rate estimated somewhere around 6%. Nationally, that's pretty good, but we hope to do better. We hope to work with this committee and others to look for ways to improve that and lower that number, getting people coverage that they need. Within these spaces here, what we wanted to show, just really quickly, I'll go through these next few slides. In Medicaid, where the membership markup is or where they're sitting today, most of the Medicaid members reside with MAHP members. I've noted all plans that serve the Medicaid population across the bottom here. There's one that is not a MAHP plan that we'll testify later, but wanted to give you an idea of that market split. And that we view as a very competitive market. It's competitively bid. It's been, quote unquote, privatized for a number of years, for a number of decades now, where the state will put out a bid. The state does not bid on price. Every member that wins an award is bidding on quality and access. Their networks, for example, are something that's evaluated by MDHHS and DTMB in that bidding process. And awards are given with the intent of increasing outcomes and quality scores of the individuals and addressing health inequities in particular in the latest iterations of the bid. We've got a rebid on the horizon. Likely you'll hear more about that in the months ahead, but later this fall we expect the state to go back out to bid that program. In the Medicare market, Medicare Advantage is now making up roughly 50%, almost 50% of that marketplace. And if you're looking at the Medicare Advantage numbers, that little smaller pie chart on there breaks down the relationships between MEHP members, Blue Cross Blue Shield, and then other carriers that may not be a member of our association but do have some market share in the state of Michigan. Again, this is another government-sponsored program, obviously, and one that, as I noted earlier, is likely to grow as our demographics continue to age. In the individual market, I noted earlier that the size, one of the things I want to note here on the remaining market slides is competition. It's something near and dear to our association's heart. In the individual market, there is a dominant carrier that exists with 48% of the market share. Our goal, our plans individually, their goals is to try to be as competitive as possible and offer people choice in the marketplace. I'm pleased to say that the number of carriers continues to grow. We've had some ebbs and flows over the years. And a lot of the pricing has somewhat stabilized. We've had a lot of ebbs and flows over the years in the individual market. Perhaps the biggest indicator on premium price in the individual market is uncertainty that comes our way from the federal government. So at times when we've had subsidies pulled or threatened to be pulled, we end up unfortunately pricing that uncertainty into premiums. In the employer market, again, dominated here in the state of Michigan by one carrier. We're hoping to increase competition throughout the commercial market for employees and employer purchasers. There's really a few different divisions here within the employer marketplace. Small group, which is less than 50 employees. Large group, fully insured, which is over 50 employees. And then your self-insured group, which tends to be the larger employees that are self-financing their plan, and we'll have a little bit more on that in a second. Important for this committee is this slide here. We spend a lot of time educating lawmakers on the levers that you all have access to influence change or increase access or change benefit design for markets for Michiganders. It's important to recognize that, unfortunately, there's nothing this committee or this body can do to influence all 9.9 million Michiganders that have health care insurance. At the two X's on here on state laws and regulations, Medicare and self-insured group, are large market swaths, right? Those are, especially in that employer self-insured group, large numbers of employees throughout the state that are receiving employer-sponsored insurance are getting it through the self-insured group. Those are often ERISA exempted, meaning they follow federal law but are exempted from most state laws. The Medicaid box has a check here, but it really is a federal and state partnership program, so there is some availability for the state to influence the Medicaid program. Social Welfare Act in particular sets up the benefit designs, for example, and licensure that DIFS regulates the health plans that are contracted with the state of Michigan, for example. They're all licensed HMOs, so there is some regulatory authority over that market, but not as complete as perhaps the employer small group or large group or the individual market. On public policies, our association does our best to identify areas where there's opportunities to explore and work with this committee and others on hopefully some policy solutions here in our state to try to get at those core tenets that I mentioned earlier of access, affordability, and equity. And so, we've highlighted a few here. This is certainly not an extensive list. This is just some of the larger groupings that we see a lot of the conversation today focused around. The first check mark here is on prescription drug spending. I can't give a presentation on health insurance without talking about prescription drug spending. It's like a prerequisite now in my job. And so, it is driving the premium for any product that we're developing that we have in the market today. And I'll have more on that here in just a second. The individual market, I mentioned earlier, there's a lot of discussion these days. There was a little bit last session as well on the potential to move to a state-based exchange or to do a 1332 innovation waiver, which may provide some greater market stabilization for the individual market on those price fluctuations that I mentioned. And we're ready, willing, and able to work with this committee and others on trying to find the best policy fit should the state want to move down that path. And then review on mandates. We see a lot of policies in previous years and some introduced this year that's focus on health benefit mandates. Obviously, there are federal health benefit mandates built in the essential health benefit that the state must follow, and there are state mandates on top of those mandates. The common theme you'll hear from me and in this committee and others is there needs to be a balance to finding the right level of care at the right price. We can cover everything under the sun at a price. And so oftentimes we worry about adding too many health benefit mandates into a base level product, that it will have a negative effect on premiums and therefore potentially make products unaffordable for individuals we're hoping to have access to it. This slide here is taken from AHIP. I want to make sure I'm giving them credit. The America's Health Insurance Plans is what AHIP stands for. They're a national trade organization of health plans. This slide's updated every couple years. This one's from 2022, so it's fairly recent here. I'll note on that far left-hand side where the drug spend is taking our premium dollars, right? That number, that 22.2 cents of the dollar, 22%, continues to increase. That slice of the pie continues to increase. And we believe, unfortunately, with some drugs at an unsustainable rate. As that amount goes up, these other areas are squeezed, or we ask for more dollars from premium payers. And at some point, there is a breaking point here for whether it's employers or for individual purchasers or for the state of Michigan as a purchaser for Medicaid. Some national statistics here on drug spend, just to give you a flavor of the rate of growth, 12% from previous year. Again, it's 2021 data, so it's a little dated right now, but we're seeing all signs pointing to 2022 showing the same, double-digit percentage growth in drug spending, U.S. prescription drug spending. This data here tracks the Medicaid expenses. The reason why I chose this is we're very rich in Medicaid data in our state because of our long history in managed care. These are month-by-month fiscal year map out of actual real expenses cumulatively of the Medicaid program within managed care. And what you see there is the cost per script or the cost per member per month. That's what PMPM stands for. And the visual here is stunning, right? The upward trend is not something that we can continue to afford. Right now, that cost on a PMPM is over $80 per member per month for the Medicaid program. These are paying providers, pharmacies, oftentimes lower amounts than market share for these drugs. So these rates are much higher on a PMPM in the commercial market. I just don't have access to as great detail data as I do in the Medicaid market. National information on drug spend, again, a few different sources here. GoodRx being the larger bars there. That's a consumer-facing website that folks can go on and look and shop and compare for prescription products. And to know which pharmacy to go to get good deals. Bureau of Labor Statistics showing the inflationary rate that has occurred and then general inflation rate in comparison. Drug costs are far outpacing, regardless of who you use as a metric, drug costs are far outpacing inflation, unfortunately. I referenced a lot of talk on state-based exchange. I won't spend a lot of time here on this, as I know at some point there'll be legislation either in front of this committee or others that I'm sure we'll have an opportunity to talk. But just did want to provide some background information that folks can review on their own time, and I'm sure we'll be meeting with members individually to go into this in greater detail. But some of our kind of key policy elements that our members believe need to be taken into account when considering should the state go down the path of a state-based exchange. And then the last couple slides here is on mandate reviews. We would highly recommend any sort of legislative review of existing mandates and external review of proposed mandates. Oftentimes, when we've seen mandates proposed in previous years, the insurance industry will come in with its actuarial data. The advocacy group that's seeking the mandate will come in with their data. and it leaves lawmakers wondering, who do I listen to? What's the right data? We've seen other states take action to create benefit review commissions or mandate review commissions as one way of attacking this, which tasks a third party, truly neutral third party, with diving into the data and reporting back to the legislature on their findings so that you can properly measure the policy objectives of increased access to benefits against the potential premium change or potential loss in access. And that's it for my slide deck. I'll just leave you all with our contact information. Christine Shearer, who was here earlier but had to run to another committee meeting, you'll see her more often than than myself, but please give either of us a call, send us text, emails, whatever, if you have any questions, if we can be of any assistance to you, Madam Chair, to this committee, to your constituents, however we can help, we want to be your resource for healthcare. Thank you.
Thank you so much for that very informative presentation. Of course, I'll be talking to you on the side about a couple things you brought up, but we do have some representatives that have questions. Representative Fitzgerald.
Thank you so much for being here today, and thank you for the presentation. It was wonderful to hear. I love these graphs that show change over time. I always wish that wage growth was also included in this, because I think that also factors into consumer health and the benefit of all the people of Michigan. But one question I did have was with regard to prescription drug spending here. On this wonderful tile slide, you note that prescriptions for mental health disorders grew rather aggressively in 2020 and 2021. While we also see an increase of more than 64 million prescriptions in those 2 years as well. I will ask you my question and my follow-up in one breath, which is, why, if we are prescribing more drugs, do we see the increase of the cost if we expect that there is more competition with the drugs produced for those potential disorders or for the treatment of those disorders? And would, in any way, supply chain difficulties contributed by COVID address any of that or account for any of that increase?
Great questions, Representative, and I appreciate them. I'll try to answer maybe in the reverse order, because the last one's a little bit easier. The data that we have actually throughout the pandemic showed that there was a decrease in prescription fills. Now, that's due in part from supply chain difficulties that you mentioned, drug suppliers, drug wholesalers, drug purchasers having some supply chain difficulties, certain drugs in particular, more so than others. And we see some of that, for example, in our state with certain drugs in the mental health field around depression and anxiety, for example. But what we saw, and again, I'll look at the Medicaid data because it's the richest data set that I have access to. Medicaid data shows us a decrease in numbers of scripts filled, but an increase in cost, right? So we're part of that is people were not going to the doctors as often as they should. We saw preventative care fall throughout the pandemic. They may be showing up at the ED more often, where they might not be leaving with a prescription. They might not be following up with their care throughout the pandemic. We've got a lot of pent-up demand that we know is there because of the utilization data throughout the pandemic. But the one thing we've seen definitely, and again, in the Medicaid data for an example, we saw that slight decrease in scripts being filled, the number of scripts, but an continued trajectory increase on double-digit increase on cost per script. The only thing I can attribute that to is the dynamic of the manufacturer, right, in that whole supply chain. The manufacturer alone sets the list price. I would contend there's not a lot of competition, actual competition, the way that the federal government handles patent protection in our country. That unfortunately is something that can't be tackled at the state level, as you know. But where we've seen generics grow, we're seeing policy changes oftentimes at the state level shifting to name brand drugs. For example, the single preferred drug list that the state launched in 2020, October 1 of 2020, moved our Medicaid single preferred drug list more towards name brand drugs and away from generics for the clear intent of seeking greater rebates from manufacturers. that has a downstream effect. Now you have people coming off of Medicaid that are now on a name brand drug. They're going, perhaps, hopefully, to a employer-sponsored health insurance plan that doesn't have the same formulary. So now you have either disruption at that client level where they're being told, I'm sorry, that drug that you've been on for the last 2 years is no longer covered by your new plan. Or they're getting the sticker shock. Yeah, that drug may be covered, but your deductible is going to kick in, and your copay, your cost share is going to kick in. So it's a big issue that we're struggling with there. On the mental health side, I would also be remiss if I didn't note in the Medicaid program, where there's a lot of mental health drugs being prescribed in our state and across the nation. This is national data that's on these slides here. The plans don't have control over the prescriptions for the severely mentally impaired SMI, the SED waiver children, the developmentally disabled population, or the SUD population. So it's something that's not a managed, that prescription benefit is not a managed prescription benefit by the health plans. The state does use a PBM, obviously, to try to get discounts on purchasing, but utilization controls just aren't there that they could be. But we've, policy-wise, have chosen not to.
Thank you.
Yeah.
Thank you. Representative Young.
Thank you, Madam Chair. Thank you for being here and giving your testimony. I kind of want to go back to the redeterminations, those who have to, like, we have over 3 million folks here in our state alone that need to reapply. I know you said, you just kind of gave a quick breeze. I know, so go back. Because I'm going to ask you to plug in some information. I'd like to know specifically what are you all doing, because the issue is trying to find people, right? I mean, just the other day I saw a short, quick little PSA, but I'm wondering, is that hitting the right audience? I mean, I saw it, I don't need it, but I don't know. So I'm always interested when somebody says that they're working, they're trying to be certain that people know that this change is coming over these next 12 to 14 months, what that looks like. If you could give me some examples, I'd appreciate it.
Absolutely, Representative, and I apologize for skipping over such an important issue. I don't mean to belittle the issue at all. It is probably one of the most daunting tasks over the next 12 months in healthcare in our state and across the nation, for that matter. The Medicaid health plans are partners with MDHHS. We're vendors to MDHHS. We are certainly hand in hand with them on this initiative to try to do as much outreach and education as possible. At the early phases, all the work that's been done has focused exactly on that outreach and education. It's trying to let our enrollees know that they need to get onto MyBridges, or they need to talk to their district caseworker to make sure that their contact information, most importantly, is up to date. So we've been doing some basic outreach. Certainly the state has done a lot more public media focusing. You're starting to see billboards and PSAs and the like in that space. But we've been doing individual outreach, trying to urge members to make sure that they're updating their contact information. And that's been going on for a long time. I mean, even without redetermination, we want proper contact information so that we can outreach to that member when they need support. Now, more than ever, though, it's got much more focus and attention. As we're moving now, first first month of individuals have received their letters from the state of Michigan. The state of Michigan sent out those letters back in mid-March, I believe. The health plans, have received lists of who received letters in that first cadre. And so now we're also devoting resources, staff, call centers, community health workers, community benefit organization partners that we make contract with to do education and outreach to them at this stage to make sure that their contact information is updated, and make sure that when they're receiving that next letter from the state of Michigan that says your redetermination process is starting, here's the steps you need to take, that we can help them through that process.
You're reaching out to people to make certain that their contact information is up to date with people who you can't find. I'm trying to understand what that means. That's really confusing. I'm not the only one. It's like, yeah, well, we sent you a letter. Oh, it came back. So do we even have percentages on who's actually receiving the information and who's not? Because that's the piece of the puzzle that I can't seem to get some clarity on.
I don't have percentages off the top of my head, but I will certainly follow up with you. And it'll be an ongoing process, so I'm happy to continue to provide some updates. Madam Chair, if you'd like it sent to you and you can distribute it to all committee members, I'm more than happy to do that. And I'm sure MDHHS as well can provide this committee with additional information on their rejection rate as well, right? I know that you know, normally it's a very high percentage that we don't have current addresses for. Right, and we're doing mail, we're doing text if we have a phone number, but again, high percentages that oftentimes are changing phone numbers. And then in some situations, we may be sending out a community health worker, but to your point, if we're sending them to an address that they're no longer at, they're not receiving that service. A lot of this is going to have to rely on the community benefit organizations that are serving these members. And our hope is that they can help as well capture for an example, when a person has moved. So if they're showing up at a food pantry, making sure that food pantry is encouraging them, hey, have you checked your address in Bridges, or have you checked in with your DHHS caseworker in a while? Make sure your information's correct so that you can get these notifications. But we're equally as concerned. It is hard work getting something to someone when you don't have their right contact information.
Thank you, Rep. Young. That was definitely an area I was going to focus on. Our final question for this presenter is from Rep. Rogers.
Thanks. Mine's real quick. It's a follow-up to Rep. Young's. She asked the main thing that I wanted to know too. Do you have any preliminary, even rough information on how many people are falling off in these first 2 weeks?
We don't, unfortunately. We've asked the department as well, and I think it's, you know, we unfortunately will find out as we go through this first cadre. I can get some information. Other states are a little further. There's a couple that are a little further down this path. Not exactly states that I would want to model our approach after, mind you, but we'd be happy to share some of that data. I can dig that up and share that with this committee and members as well.
Sure. Yeah, I was really disturbed to hear the number. I met with my local FQHC this week, and the number they threw out was 50%.
I think, you know, when we look at the enrollment growth, we saw about a 30% enrollment growth in areas. But to the point of contact information, that the concern here is people that legitimately should remain on the program being dropped off. Now, I'll say, and again, the Department of Health and Human Services is the better entity to ask for more details on this than myself, but they are doing a deeming process where they'll look at other information they may have. So, for example, if the individual's enrolled in CHAMPS and they know, and they've had that reevaluated for income or assets or whatever might be tested for another social support program, they have a process and they will re-enroll that individual into Medicaid even if they're not contacted or if they're not filling out the information, if they know that they truly are eligible. But yeah, it could be a very scary number. Yes. Thank you.
Thank you for your presentation. I did have a lot of questions, but I'll follow up with you
I'll
on
be
this.
happy. Yeah,
Thank
happy
you
to meet
so
with you.
very much.
Thank you, Madam Chair.
And our final presentation on our agenda today, we have here with us Mark Cook. He is the Vice President of Government and Regulatory Affairs for Blue Cross Blue Shield. Thank you for coming. The floor is yours.
Good morning, Madam Chair. Getting the presentation pulled up here. Appreciate the opportunity to come before you and the committee, good morning, committee members, to discuss a little bit. Well, there's some overlap with what you heard from Don, but a little bit of this will be more specific to Blue Cross and hopefully answer any questions that you have at the end as well. So as noted, I'm Mark Cook. I'm Vice President of Government and Regulatory Affairs for Blue Cross Blue Shield, and I'll tell you a little bit about our company. We are Michigan's largest nonprofit insurer. We were founded in 1939. We were the insurer of last resort in the state prior to the ACA passing that required everyone to take everyone. But we've been committed to that for a long time. We have about 6.1 million folks that we serve nationwide, about 5.1 million of those in the state and about 1 million outside of the state. And those outside of the state are for retirees. We have big population in Florida and big population in Phoenix, as you might imagine, from Michigan. And, but also folks that are employed by Michigan-based companies that work in other states. So, for example, if you're building Tahoes for GM in Texas, you actually are insured by Blue Cross Blue Shield of Michigan. And we have an agreement with the Texas Blues Plan that they pay their coverage, and then we cover any folks that they have based in our state. So that's how part of the Blue Cross Association works. We are headquartered in Detroit. We have more than 8,000 employees in Michigan across the state. We have the largest network of doctors and hospitals, and we are very proud that we're a workplace diversity, disability, equality index score of 100 out of 100 points. So we're very committed to diversity and inclusion as well. And roughly we pay over about $80 million per day in claims and benefits. Those are 21 numbers. That's a little higher in 22, but just to give you an idea. Talk real quickly about how the Blues Association works. So we are a licensee of the Blue Cross Blue Shield Association, which is based in Chicago, but we're like the Michigan franchise, if you will. That's probably the easiest way to understand how that works. So again, as I mentioned, if you're anybody that has a company like General Motors or Ford that's based here, but they work elsewhere, we cover those folks. And or if you're traveling either in the state and you need to go to a hospital somewhere, that Blues plan there will cover you, and we'll work it out on the back end. So it's or if you're traveling internationally, state of Japan, for example, Madam Chair, we have a program through Blue Cross Association called Geo Blue that helps cover the international things too. So the card travels very well. That's one thing to note. We also have subsidiaries. We have Blue Care Network, which is our HMO in the state, and that's based down in Southfield, but it covers everybody around the state as well. The AF Group, most people know it as the Accident Fund, which is headquartered here in Lansing, and that is the largest workers' comp carrier in the state of Michigan, about the 5th largest nationally. So they write in every state, and that is formerly a state agency that was privatized in the mid-90s and has grown and done very well, and those folks are employed here, which is great. LifeSecure is a company that started out doing long-term care insurance, but has morphed into doing some more, we'll call them like Aflac-style plans, a supplemental insurance, hospital-only specific disease insurance, those types of things. And then Blue Cross Complete, as was mentioned by Dom, is our Medicaid managed care company, a subsidiary. So they handle some of the Medicaid population, as was noted. And then at the bottom is the Blue Cross Foundation, which gives grants for research and doing demonstration projects, et cetera, in the state. So we're driven by a strong mission, and we keep our goal is to keep margins low and improve affordability, and I'll talk about margins here in a second. But affordability and accessibility go hand in hand. I think Dom talked about that a bit too, which is if it's not affordable, it's not accessible. So if the rates get too high and people can't afford it, then people don't have coverage. And so we're always trying to walk that balance. And you'll hear, I'm sure, from providers that would love to have us pay them more. We hear from our customers who would love to have us pay those providers less. And the goal is to try to find that very thin line of trying to pay providers enough that you have a broad network, and we do have the broadest networks in the state, so they have a lot of folks participate, which gives good access to our customers, but also not pay so much that it keeps, so we can keep rates low. So that's the balance that we always try to walk. As I'd mentioned, we've been committed for a long time to providing insurance for all, and we're deeply committed to the communities in Michigan, and we do a lot of work in our social mission area. I'll touch on that in a moment. This is a little bit different look of what Dom showed, but it's our breakdown of how our membership is composed. And so our individual products cover about 4% of our total book. And then you'll see we break down our government products, which is about 14% of our book of business, into Medigap. Medigap is for folks that are on traditional Medicare, not the Medicare Advantage, but then buy gap insurance to cover what Medicare does not cover. So that's about 3% of our book there. Our Medicaid book is about 5% of our coverage. And as noted earlier, that's a little over 300,000 covered lives in Michigan. And then Medicare Advantage and the Part D and Medicare together are combined about 6%. Most folks in our book are employer sponsored, and then there's a breakdown there of the small group, large group, and self-funded. What I'll note is for our self-funded is roughly 60% of our book of business. So those are the very large employers, typically state of Michigan, GM, Ford, Meyer. Some of our larger customers that are very sophisticated. They have their own benefit designs, many of which have been negotiated through collective bargaining or are part of their benefit plans for their employees rather. And we're essentially paying their bills with their money through our networks. So it's not really insurance from the traditional standpoint. It's they're self-insured, they're holding the risk, but we're acting as a benefit administrator for them. And that is by far, as you can see, the largest part of our business. And just quickly on competition, which was mentioned by Dom, which is these are very large, very sophisticated employers that can get coverage by anybody they want to. So we're very pleased that they choose us, but it is certainly not because they don't have other options. And I think it's a misnomer to say that that's the why. So let's talk a little bit about our investments. As I mentioned, we're very committed to our social mission, and we have contributed over $710 million to the Health Endowment Fund. The Michigan Health Endowment Fund has a mission to improve the health of Michigan residents with a special emphasis on the health and wellness of children and seniors while reducing the cost of health care. They give out grants for a lot of really worthwhile projects out there, and we are committed to giving $1.56 billion to them over an 18-year period. And we're, I said, I think we just gave another $100 million, so we're at $810 million that we've contributed so far toward that $1.56 billion commitment. We're also very proud to be the largest private funder of Michigan free clinics in Michigan. We've given over $18 million to free clinics in the state. We think it's an important access point for folks to get coverage, and we want to make sure that those stay viable and are an important part of the overall healthcare fabric. We also are very involved in building healthy communities. These are grants that we give out to school districts. This has been very successful. There's over 1,100 schools and over 500,000 students that have been participated. It's grants for things like improving healthy food choices in schools, playground equipment, to help build habits of healthy lifestyles. And those have been shown by research to reduce obesity, increase physical activity, and healthy eating. It also improves academic achievement. So those are some of the programs we're very proud of. I want to talk quickly about value partnerships. This is an umbrella of programs that we utilize that we think are really kind of changing the fabric of healthcare in Michigan over time. And what we do with these value partnerships, it's a risk-sharing arrangement with providers. So traditionally, insurers pay every time somebody pokes somebody, every time somebody gets a particular treatment. You're paying for the service, like a fee for service, as opposed to paying for outcomes. This is trying to shift the model by doing some risk sharing with providers, hospitals, and physician groups, practices to pay for outcomes. So the idea is, someone presents to you, they're ill, you make them healthy, and we will pay you for making them healthy. And if you're able to do that in ways that are cost effective and increase quality and don't have folks that have to return back to the practice, then you get incentive payments for that. And so the idea is to try to shift people away from a fee-for-service model to a pay for outcomes model. And we think this has been very successful. It's resulted, as you can see there, with some good results, fewer ER visits, and we have about 2.9 million members now of our membership in Michigan that go through a PCMH, which is a patient-centered medical home. That's one of our programs to say that they have a medical home that they go to, a doctor that they see that is, assigned to take care of their care. And we think that's having some really good outcomes. You've seen this. I'll just call out, this is the same dollar that Dom showed you from AHIP. I also wanted to call out the prescription drug cost, and I'll talk about those in a second. The only thing I'll point to you that's a little different on this one is down in the bottom right-hand corner, where the national average is a 3.6% profit margin for health plans. We have a 10-year operating margin of less than 1%. So that is part of that social mission of ours and our nonprofit model. Again, prescription drugs, you've seen lots of charts. They all look like this with a slope going up. And prescription drugs is the biggest challenge that we have, like Dom's members as well. And the issue, United States and New Zealand are the only two countries in the world that allow direct-to-consumer advertising for drugs. There's a reason for that. All those ads of the happy people playing pickleball and the fun music and all that stuff going on, that costs a lot of money. And we're all paying for those. So every time you see an ad, just reach into your pocket, throw some money at the TV. That's part of what's happening out there. So something's got to give somewhere, and it's more of a national issue from a regulatory standpoint. But we wanted to make you aware that is really driving the escalation that we see and the cost pressures that we see. I call out one number I wanted to throw at you that I thought was pretty shocking. The median new drug price in 2022 was $222,000. And the most expensive new drug price that was approved is $3.5 million per dose. So, again, that's a median number is $200,000. So it's not just the drugs that we're paying for now that are increasing, and the drug companies that have, bought up the generic companies and jacked those prices up too. The challenge that we have is the pipeline that's coming down the path on some of these specific cancer drugs and some of the things are really, really expensive. And somewhere something's going to have to give. So I just want to call out to you that it's a growing problem. It's not going away. It's something we all, I think, as policymakers, you all are going to have to grapple with. So on a good news piece of note, I wanted to call out that, this is from a Forbes article. Michigan actually is one of the least expensive for healthcare in the country. So if you look at, this is like cost per member in the country. We have the 6th lowest healthcare spending per person in the last 5 years. We have individuals with employer-provided insurance have the lowest premiums and lowest deductibles in the nation. And those with family health coverage through an employer have the 3rd lowest deductibles. And then individuals with health plans from the ACA in the marketplace have the 4th lowest premium in the country. So we are doing some things right. We like to think that we're certainly part of that equation as some of the value partnerships and some of the things that we do with hospitals and providers to try to keep costs down in Michigan. But there's still challenges out there. But I wanted to at least have some good news. So. Dom talked about these a little bit. I'll just touch on them quickly. But there are utilization management tools that we use. A couple examples are prior authorization and step therapy. You will have folks come in and tell you that these are the things that are big challenges for getting consumers care. I will tell you that these are tools that really help prevent fraud, waste, and abuse. We think it's very important that as we, as a fiduciary for our customers, many of whom are employers that, again, we're paying their bills with their money, that we're making sure the money is actually going to appropriate care. We have a lot of data. We get a lot of information about what people get treatment for certain diagnosis codes. And we plug that all into databases and say, okay, most people are having good outcomes with this type of service with this diagnosis. So we know that if things there are outliers to that, if there are, providers that are saying, well, I'm going to have them do this, well, like, we know what works. So we try to use prior authorization and step therapy to try to make sure that we're getting appropriate care. Last thing I want to touch base on is mental health care. Everybody knows it's a big challenge in the state. I just wanted to call out one of the important things that we're working on, that we're having some good success with, is this collaborative care model. So what we did basically is we're trying to move care and treatment for mental health into the physical health provider space. And so we've got a program where we train doctors and practices to be able to, so you can go to your medical doctor and get mental health treatment. This does, it removes stigma and gets more access to care for people. So we put this model together. We've trained practitioners. We've incentivized practices, large doc practices, to incorporate mental health into their practice. And we're having some really good outcomes. So I can, happy to talk offline. I know we're running short on time on some of those things, but I just want you to know that it's something that we're trying to address, and we've had some good success with this model. This is my wonderful team. You see Chris and Gabe a lot more than you see me. Amy is out in DC doing good work out there, but we also want to be a resource for you on anything that you might need as you're thinking about all the challenges and policy questions before you all. And with that, Madam Chair, I appreciate your time.
Well, thank you, Mark, for this wonderful presentation. You and Dominique pointed out what appears to be the 800-pound gorilla in the room. And I know as my colleagues look at some of the cost of oral chemo drugs, the cost of insulin, okay, which is really on our radar right now. What is Blue Cross Blue Shield doing to address the high cost of insulin?
It's a great question. And one of the things that we did about 2 years ago, we saw all these challenges as the manufacturers were jacking up the prices of, at well above the rates of what any costs they had. 600% increases in insulin drugs. So we invested in a company called Civica RX, which is a developing biosimilars, which should be on the market in 2024 if the FDA approval and everything goes according to the plan that they're doing. Because what we were running into is, as I mentioned, the manufacturers would buy, you'd come out with a generic, a manufacturer would buy the generic company and jack up the price of the generic as well. And so it would lower the difference between. So we weren't having, we early on had a bunch of success. We had generic programs to try to push people toward generics. When that started slipping away from us, we invested in this company called Civica RX. There are other nonprofits. I know the Trinity Health System is heavily invested in them as well. Their manufacturing plant is coming in line in Virginia later this year, and we're hopeful that we will have low-cost generics. Their target price is like $30 a unit, as opposed to the multi-hundreds and thousands of dollar units that are out there now. And we think that's already had some pressure. As you've noticed, Eli Lilly and others recently have made some announcements in that space. But that's one of the things that we were doing to try to address that. But great question. Thank you.
Thank you. We have a couple more questions. Rep. Young.
Just really quick, and thank you, of course, for your testimony.
Sure.
You touched on a pet peeve a little bit. I'm trying to figure out the right way to put it.
Sure.
But those prior authorizations and that process, and when there are maintenance types of doctors that you need to go see, like your allergist and all those things, and still having to get these pre-authorizations like annually, is there a way to streamline that process?
No, it's a great question. And one of the things we have is that we have it's called a gold carding program, where we will go into certain providers that we know, again, we have a ton of data. So we know who always generally tries to do the right thing. So certain providers, and we're looking to expand it, which will say, look, this doc practice, and we know that they have, we see their data, we know that they have really good prescribing, referral habits and all that. You get gold carded, you don't have to go through the prior authorization process as long as you maintain these great standard numbers that you have. And that's something that we have that now, and we're looking to expand that. Prior authorization typically tries to catch outliers, as I had mentioned, in order to, look for fraud and abuse, but the goal is not to keep people from care they need, right? Because we don't want anybody in the ER either, because that costs more money as well. So we're looking at expanding the gold carding program, and I know that's something that we've even been working with MSMS on. I should mention too, you gave me the opportunity, our board is made up of our subscribers. We have big employers on our board. We have labor on our board. We have docs. We have hospitals. We have a dentist on our board. We're very collaborative in trying to work with the hospitals and the docs in the state to try to ease through some of those challenges. But the gold carding program is the one that pops in my head to be the one that I think that will really help with that area. Yeah.
Thank you, Rep. Young. And our final question is going to come from Rep. Bazat.
Thank you, Madam Chair. I appreciate it. Great presentation. Both you and Dom did a great job. Very complicated but I've always been curious, and I hope I don't put you on the spot here. You brought up Arizona.
Yeah.
And I have a ton of friends down there that are retired from law enforcement. And their community, there's quite a few of them that'll travel over to Mexico because of the drug issue.
Right.
And buy it cheaper.
Yeah.
I've always been curious of why.
Yeah, Canada as well is another area where they just have cheaper drugs. The manufacturers set the base price. They sell the same drug that they made in Mexico cheaper than they sell it in Canada. And they sell it for the most in the United States. In part just because they, again, those ads that I talked about and everything else. So that is something that could be more regulated at the federal level. But I will just tell you that pharma has a very strong lobby voice at the federal level, the Manufacturer Association for the pharmaceutical manufacturers. And so it's been a challenge to try to get any, price regulation or anything there. But we would welcome any conversations about price regulation, anything that would help address that'll help keep those premiums down. So, yeah.
Okay. Well, once again, thank you for the presentation, Dominic. I think he's gone, but thank him as well. So
He didn't stay for my presentation.
Oh, but anyway. Okay. Right now, we need a motion to excuse Rep. Grant. Okay. I see. Rep. Scott has moves to excuse Rep. Grant. If there's no questions, she's excused. Okay. Seeing no further business before the committee, we need a motion to adjourn. Rep. Nair moves. If there's no more objections, we are adjourned.